How many of you are awake? Okay. The people who haven't raised hands, should I assume you're sleeping? No. Okay. So you heard colleague deliver an excellent lecture on acute leukemia and immunophenotyping. Now I'm going to talk to you. We are going to switch gears to lymphomas. So we are basically covering B and T cell clonality. So before we go any further, what do you understand by clonality? So that is lineage. That is not clonality. Lineage is B, T, myeloid. That is lineage. What about clonality? Yes. So monoclonality, what do you mean by monoclonality? Okay. So effectively, what we are talking about is cells that are malignant, and these cells, they are usually existent in a continuum of clones. So let me go to my slide. So this will be the outline of the talk today. So what is clonality? If you look at this cell, this particular B cell in the normal peripheral blood, you see that each of these B cells have a different kappa or lambda light chain on their surface, right? So this is a different antibody that each of these cells are expressing. So this is a group of cells which have a diverse kind of expression of the immunoglobulin gene. However, if you look at this, what has changed? You have out of the seven things, seven of the cells, they show you the exact same immunoglobulin on the surface, right? So this means that they are clonal. So these cells, they originate from one single transformed lymphoid cell. So they have the same immunoglobulin gene rearrangement in a B cell lymphoma, or in a T cell lymphoma, the T cell receptor gene rearrangement. So this is the premise of clonality. So reactive cells will have a diverse immunoglobulin or TCR gene rearrangement, while clonal cells will have restricted immunoglobulin or TCR gene rearrangements. So when we talk about clonality, what are the methods that we can use in a B cell? How do you know that a B cell is clonal? So you can access the gene, right? If you're accessing the gene, you target the immunoglobulin heavy gene or the kappa or the lambda, right? So you can use it if in the early techniques, 1990s, 80s, people used to use southern blot. Very, very cumbersome, very, very difficult to do technique. Then came the Euromed consortium. So the Euro PCR group, Euro MRD group, they gave these primers, which are for the three genes that we talked about, and they can be used in a multiplex manner to study for these rearrangements. Now with the advent of NGS, even NGS-based assays are available, except for the prohibitive cost that they have. A simpler solution would be to study the proteins that these cells are expressing. So what are we doing by flow cytometry? We are analyzing the cell surface expression of proteins or intracellular expression of proteins. So for a B cell, that is kappa or lambda, right? So each B cell, dependent upon how it has matured, what antibody, what light chain got rearranged, it will express either kappa or lambda, right? So when you have a when you have diversity, when you have B cells of many types, some of them will express kappa, others will express lambda. While if you have a monoclonal B lymphocytosis or a B cell which is derived from a single cell and that clone is expanding, it will either express kappa or it will express lambda. So that is the premise of doing this clonality assay. So when we talk about the molecular methods, on the left you have an image. So on the left, you have the image of a southern blot. This is the multiplex PCR and has been analyzed by a gene scan and capillary electrophoresis. And if you have a look at this is the NGS, where this is the kind of clonotype that they derive. And if this kind of clonotype doesn't exist, or if this green clone becomes the majority clone, you can say that something is monoclonal. So this is the long list of primers that EuroMRD used. And till today, when you find publications of BALL MRD, you find that most of Europe would stick to molecular MRD for BALL, because this is something that they have standardized and implemented extensive quality control on. So when are usually molecular methods used for clonality assessment? So usually it is when the discrimination between a lymphoma and a reactive population is uncertain, when you have certain sites which are difficult to access or difficult to get out tissue from, which you can flow, such as the skin, sometimes in context of immunodeficiency, and lymphomas where you have a combination of cells. For example, in AITN, you may have atypical B as well as T cells, one of which may dominate, and the T cell clone, although it is the pathological clone, you may miss it. And in addition, when you have ALCL, where not many of the T cell antigens are expressed, there you might need to resort to clonality assessment. However, this is not the normal scenario for us, and that is why life is a little bit easy. There are caveats to the molecular technique as well. You have all heard of EBV. EBV infection, many times it causes infectious mononucleosis. Sometimes the cytopenias, they keep persisting even after the patient is treated. So there are oligoclonal T cell expansions even in the normal viral infections. So if we do an assay on the molecular MRD, we may identify these small clones which are present, and they may not be indicative of a T cell lymphoma. So not every oligoclonal T cell expansion is a T cell lymphoma. These can be transient, and if you don't have the rest of the polyclonal cells, so if you go back to the image of the gene scan here, yeah, so of the gene scan, you realize that this is the kind of polyclonal background. So if the polyclonal cells are not there, or if your sample is very, very limited to a few T cells, then you may get peaks which may look like monoclonal when the actual sample is polyclonal. So this is one of the limitations. And when you have a lot of polyclonal cells and you have a small abnormal T cell clone, then also you may miss it. So these are limitations. The biggest thing that we need to remember is that clonality is not always equal to malignancy. A malignancy will be clonal usually, but not all clonality will be malignancy. So when we talk about B cell lymphoma, the primary thing that we do for clonality assessment is assess surface kappa and lambda staining on the population of interest. So malignant B cells, as I just explained, would express either kappa or all of them will express lambda, right? Remember that in a normal sample, you will also have, or so in any sample, you will have some residual normal B cells also remaining. So even if a patient has CLL, they would still have some normal B cells sitting around. Okay, so those normal B cells will express either kappa or lambda, or they will actually show a split between kappa and lambda. So they can become a useful guide to the intensity of kappa and lambda, to the part whether kappa and lambda have worked or not. And also they tell you whether your abnormal population is sitting on one end of the tube or not. So how do we know whether something is normal or abnormal? So when you stain B cells in a normal sample, the kappa to lambda ratio is approximately 2:1. So now, if it is 2.2:1 or 2.4:1, should we call it abnormal? Thankfully, no. So this is the ratio that has been given. So the target is kappa to lambda ratio of 3 or lambda or 0.3. So it is both way, the figure is like that. So kappa to lambda 3:1 or 0.3:1. Okay, so 3 times the leeway they have given. If it is outside of this range, then you should suspect monoclonality. So for B cell lymphomas, usually you do surface assessment because these B cells, they express this immunoglobulin molecule on their surface, right? However, if you have to assess plasma cells, what is the job of plasma cells? Normal job of plasma cells? They make immunoglobulin, right? So they have the immunoglobulin assembly within their cytoplasm, but once they make the immunoglobulin, they usually dump it into the bone marrow sinusoid. Why? So that it can come into the circulation. So they don't express immunoglobulins on their surface. So because of that, we have to permeabilize the cell and do a cytoplasmic kappa and lambda processing if we have to assess the plasma cells. Okay. Now, in that context, say if you have a sample of bone marrow where you have permeabilized, you have gated your plasma cells and you want to assess plasma cell clonality. Say if there is a B cell clone sitting there, it would again still show clonality for kappa or lambda. Why? Because in a B cell, because of something is on the surface, how has it come to the surface? The cell produced it, so it came to the surface. So it is not that when you're using cytoplasmic markers, you cannot assess clonality on B cells. It is just that doing that cytoplasmic processing is a cumbersome additional procedure. It induces artifacts. So till the time it is absolutely required, I think none of us flow cytometrists would want to permeabilize the cells till the time we need it. Okay. So can anybody tell me which populations are normal or abnormal? So in many of my plots, you will see, sorry. in many of my plots, you will see that there are two markers tagged together. For example, here on this plot, you have 56 and kappa. So Dr. Kharik mentioned that you can have 10 color tube with 14 markers, 12 markers, 13 markers. Why? Because 56 and kappa are not expressed on the same cell. So 56 will be either expressed on the NK cell or on the T cells, which are NK T cells. Kappa will be expressed only on the B cells, right? So we use this approach. It is also called as the sentinel approach. Similarly, if you look at the if you look at the x-axis here, that has CD8 and lambda. Why 8 and lambda? Because 8 we are assessing on the T cells, and lambda we are assessing on the B cells. So as long as we are able to get our T and B cells separately, we can club these two antibodies on the same channel to ensure that we are able to do more markers with less number of colors. So the plot on the left, do you think this is clonal? So these are B cells. On the top, you have B cells. So we are talking about B cells on all the plots. So there are only two options, yes or no, clonal, not clonal. So let us raise hands for clonal. Okay, clonal. Okay, most of you think it is clonal. What about plot B? Clonal, non-clonal? Clonal? Okay. What about the third plot? Clonal, non-clonal? Non-clonal, right? So for third, I think all of you agree that this is non-clonal because your cells, they are splitting between lambda and they are also, there is one population that is kappa positive, other population that is lambda positive. Now, for those of you who did not think that these populations are clonal, may I ask why? What were the thoughts in your mind which led you to not call this clonal? If any one of you would like to share. Yes, so this is positive for kappa, right? The intensity is variable. It is sort of ranging from dim to moderate. It is not bright where the normal cells usually are, but this is definitely clonal. And you have a small population of these polyclonal cells, which are lambda positive sitting over here. So some polyclonal cells here, some maybe over here, but definitely the larger chunk is monoclonal. Now in the other plot as well, you can see some normal B cells here, which are lambda positive. However, you cannot see the normal polyclonal kappa cells because your malignant cells, they are very bright positive for kappa. So they are also definitely clonal. Okay. I think one reason why some of you did not was the fact that I haven't put quadrant gates here. Is that true? If I would have put quadrant gates, given you percentages, then maybe you would have felt that these are clonal. You could have calculated the ratio in your mind. But understand that in flow cytometry, we're trying to move away from percentage expressions, quadrant gates. Why? Because they can sometimes give us false ideas and we can imagine things that are not existing just because the gate is wrong. Okay, so how many of you remember Hemant talking to you about issues with kappa lambda staining? So Dr. Hemant discussed that in the morning, right? So I also remember that. So why are these issues very important? Let us look at cases, a few cases which highlight the problems that I have faced for kappa and lambda staining over a period of time. So this was a 45-year-old male with IgM lambda M spike of 3.5 gram per deciliter, and we received a bone marrow for immunophenotyping. With an IgM lambda M spike, what do you think the patient has? Okay. So plasma cell myeloma. Usually in plasma cell myeloma, what is the type of immunoglobulin? IgG, right? If not IgG, next most frequent? IgA. Otherwise, just a light chain only myeloma, right? So here, what is the M spike? IgM lambda, right? So Waldenstrom's macroglobulinemia would be a more likely differential. It is not that IgM myelomas cannot exist, but just by going by the frequency, very likely we will have Waldenstrom's on our hand. So we did this LST tube, and in this tube, CD19 and TCR gamma delta are multiplexed. So these are T cells. These are the TCR gamma delta positive T cells, while all these cells, they are actually B cells. Why? Again, the same approach is being utilized, that 19 expressing cells will not express TCR gamma delta, while TCR gamma delta cells will be positive for 3. So on this bivariate plot, whatever is positive for CD3 is a T cell, and on the 3 versus 19, whatever is not positive for 3 and is positive for 19 becomes the B cell. So these B cells, and I just want you to concentrate on this plot. So what do you think about clonality here, kappa or lambda? Do you think kappa or lambda has worked well? No, right? You cannot see the normal B cell clone. You don't see the abnormal cells expressing kappa or lambda. So definitely this hasn't worked, right? So this was the lymphoid screening tube. Usually for Waldenstrom, sometimes the RBC lysis can be a problem. So therefore, we had processed it by a lyse stain wash approach, but we had used only one wash. So now in this approach, we washed the entire sample together and then we did the staining and then we lysed it. The volume of wash used was 1:10 ratio. So if we had 300 microliter of sample, not even 1:, it was actually more than that. So 300 microliter in 10 ml of PVS was the wash. So now, so the plots look a little better. And now can you comment on the clonality? Do you see something here popping up in kappa? Yes. So these are the normal kappa positive cells and these are the clonal B cells which show a restriction for lambda. What was the M spike? IgM lambda, right? So these cells, they are clonal for lambda and we had missed it in the initial setup. Okay. Why did that happen? So for kappa and lambda staining, there are certain key points. The first of these key points is that these antibodies will also bind to the free kappa, free lambda in your system, right? So whenever we have a whole blood sample, we have plasma, we have WBCs, we have RBCs, and we have platelets, right? So if the plasma contains a lot of kappa or lambda, free kappa or lambda, then also these anti-kappa, anti-lambda antibodies, which are fluorochrome conjugated, they'll go and bind to those antibodies and not bind to the receptor present on the cell surface. So therefore, sometimes you may not get any staining if you don't wash your sample twice with PBS before you start your staining. So most of the time for kappa or lambda staining, you would prefer a lyse, wash, stain, wash approach. And I'm saying lyse, wash, why? Because usually after lysis, we do one wash and the sample is good to go for a routine leukemia lymphoma flow analysis. However, if you're doing kappa lambda staining, additional washing steps are recommended. So for Euroflow consortium, they don't recommend lysis as the first step, but they require high volume washes to ensure that all the plasma has been removed. And the lyse, wash, stain, wash approach will work better. Now, this was something that Hemant also showed you in the morning. This was from Dr. Sindhu Cherian's paper, Pitfalls in Flow Cytometry. And this is no wash, one wash, two wash, three washes, and this is three wash with blocking, right? So what do you see? No kappa lambda, to some amount of staining, good amount of staining. By the second to third wash, you see that the staining is largely okay, right? Your populations are separating very well. Now, after the blocking, what do you see? You have these cells which are sort of moving up. They sort of come down, right? So that is one advantage. In addition to that, what does it prevent? So when you heard about non-specific binding in the morning, what were the types of non-specific or non-specific fluorescences? One was autofluorescence of the cells itself, right? There was something else which was called as non-specific binding, right? Dead or dying cells will exhibit non-specific binding to antibodies. Then a third term was referred to, which was called as specific but undesirable binding, right? So imagine an immunoglobulin molecule. It has the FAB arm and the vertical arm is the FC arm, right? So which are the cells which normally have FC receptors? Monocytes, right? So monocytes have FC receptors, and if they bind to your anti-kappa antibody, imagine that this is not a target cell, but this is this antibody is still present in the system. So if FC receptor will bind to anti-kappa antibody, that will also exhibit background fluorescence. So to avoid that, if you in your last wash put some amount of DSA, it takes care of this FC binding. Even if you don't, it still normally will not trouble you much. So that was key point one, that washing is essential when you're doing kappa or lambda immunostaining. Now, yes. Yes, so okay. So IgM molecule is based on the heavy chain, so it has the mu heavy chain, right? Now, normally any immunoglobulin, be it G, A, M, D, or E, will always have concomitant light chains, right? That is how the complex will be formed. So the heavy chain forms this arm, and on this side you have the light chains, right? So when you have a monoclonal B cell, if it is expressing IgM, it will also express the light chain. So M means the heavy chain is M mu, and the light chain expressed by that cell here was lambda. You got it? No. So for IgM lambda, the report comes from a test called as immunofixation, right? So immunofixation was done in which you add antibodies to the heavy chains GAM, kappa and lambda, and then you note where the bands are appearing after electrophoresis. So that was on immunofixation. Now we'll move for the second point. So in this case history, you have a patient who had abnormal large lymphoid cells of about 18%. You can see one of them in this. In addition to that, there was leukoerythroblastic blood picture. So now flow was performed. The same gating strategy. Here B cells are magenta. And if you have a look at this, you realize that 38 is very, very brightly expressed, but there is no 20. Do you think that is normal? So 19 positive cells, 38 positive cells, lacking 20. Pro B cells, okay. So pro B cells is one possibility. What else? Targeted therapy. So targeted therapy, anti-CD20 therapy, if the patient has received, that is a possibility. What can be a normal population that can sit in that area? Plasma cell population, right? But here, these were not plasma cells, they were CD5 negative. One more abnormality, can you spot on this plot? Kappa and lambda? Negative, right? So we review the washing, we realized that we followed the Euroflow protocol for washing. Washing was okay. So atypical features are lack of 20 and no working of the kappa and lambda antibodies, right? So there was a prior history of Rituxan therapy, so we could explain away the lack of CD20. This was the further tube in which you realize that these cells, they express CD10, nicely positive for 79B. In addition to that, they also express 43 at a dim intensity, right? So we have a CD10 positive B-cell lymphoma, which has been treated previously with rituximab. So what are CD10 positive lymphomas? Can you give me a few examples? Follicular lymphoma, DLBCL, Burkitt's. Very good. So these three germinal center B-cell lymphomas are there. So the key point too for kappa and lambda staining is that the choice of your antibodies is important, right? Why is the choice of antibodies important? Usually when we talk about flow, we talk about monoclonal antibodies, right? Monoclonal antibodies because we want to target one specific epitope. For kappa and lambda, I think all of us who practice flow cytometry would always prefer polyclonal reagents, even though that is still not a guideline. Many of the manufacturers don't have polyclonal reagents, so they give you monoclonal reagents. But polyclonal reagents from other vendors may be available to you in the market. And this is especially true for germinal center lymphomas. Why? Because what happens in the germinal center? What happens to the IgH molecule? They have somatic hypermutation, right? So when we repeated the panel in this case, using the polyclonal reagent, so our LSC tube was a custom tube from BD, which the BD sells, and that has monoclonal kappa and lambda reagents. So we also used to keep polyclonal kappa and lambda reagents at hand. So when we use polyclonal reagents, what do you see? That the cells now are clonal for lambda, right? Clear clonality is there. So one of the issues we could solve by history of Rituxan therapy. The other issue we solved by using polyclonal reagents. So germinal center lymphomas may lack clonality if you're using monoclonal light chain reagents because there are ongoing somatic hypermutations. The particular epitope that is targeted by your anti-kappa antibody or anti-lambda antibody might have been deleted in that somatic hypermutation. So it will give you a false appearance that nothing is expressed on this cell. And it is important to use polyclonal reagents to resolve clonality in such cases. Now, this was another case in which we received FNAC of an abdominal lymph node. This was not a preferred sample for us, but in this patient, multiple EUS guided biopsies had shown only dampened follicular hyperplasia in the abdominal nodes. So these cells were gated, and if you have a look at the plots, you realize that you have T cells, you have B cells, NK cells would not be there in this FNA in a much high number in a normal scenario also. However, on the 20 and 19 plot, can anybody appreciate two populations here? Something that is bright for 19, dim for 20, and then the other population which is bright 20 and dim 19, right? So if we draw these two circles around it, so this is the gating that is done. If you have a look on the 19 versus on the 19 plot, you can clearly see this 19 bright population magenta, 19 dim population green. And when you look at kappa and lambda, this pink population is nicely splitting into two parts, right? So one is kappa positive, other is lambda positive. Definitely polyclonal. What about the green population? It is negative for both, right? It is not expressing kappa, it does not appear to express kappa, it does not appear to express lambda. So we repeated this tube. Incidentally, we had some more material, so we could repeat it. And here again, polyclonal reagents were used. And if you actually have a look at the BCLPD component, CD10 is positive in this particular component, right? The 20 bright, 19 dim component is also CD10 positive. And now the clonality for lambda is sort of popped up, right? So again, the same point, polyclonal reagents, yes. But this was the baseline when we were using monoclonal reagents. However, what I want to here say, and I've already talked about polyclonal reagent, is that if you have a CD20 bright positive B cell, it should express a light chain. It may be clonal, maybe not clonal, but it should have a light chain expression. So it should either express kappa or lambda so that you get a mixture of both in normal, or you get a monoclonal population if it is abnormal. So if you have lack of light chains on the 20 bright positive B cells, that also signals an abnormality, right? What I mean to say is that this plot on the left is an abnormality. This is an unexpected finding that you have in this case. So that is something again that we keep in mind for germinal center B-cell lymphomas. Now with that, I'm showing you one more case which was evaluated for incidentally detected lymphocytosis. And if you have a look at it, you have your B-cell population nicely sitting here. What about 20? Would you call this 20 positive or not? Not. Dim positive, heterogeneous positive, heterogeneous positives, okay? Heterogeneous, it ranges from negative to dim. Okay, so what about CD5 on the B cells? It is dim positive, right? So it is 5 positive. And when you look at kappa and lambda, it again does not appear to be working, right? So one review that I taught you was polyclonal versus monoclonal. Here, monoclonal antibodies were not used. It was polyclonal antibodies that was used. Review of staining process was done. It was lyse, wash, wash, stain, wash approach, and 2 washes had been given post RBC lysis. So the tube was repeated. It looked nearly the same again, right? So we went back, looked at the other phenotypes, and this was chronic lymphocytic leukemia on the other tubes. So not all mature B-cell lymphomas will always have surface light chain expression at an intensity which you can resolve. This is especially true for CLL and SLL, which has very dim expression of light chains even in a clonal population, right? So sometimes the CLL cells may show you absent light chain expression. Don't worry about it. Don't run after it. Just remember that in your normal sample, you also have hematogones, especially the early hematogones, which will not have kappa or lambda light chains. So don't get hassled if you have cells that are negative for kappa and lambda. Now I'll show you 2 more cases and then we are done with B-cell clonality. So we have a 56-year-old male who had incidentally detected lymphocytosis, no symptoms, no organomegaly, no lymphadenopathy, no B symptoms. If you look at this, he basically has leukocytosis and absolute lymphocyte count is 5,543. So we ran the plots. Basic plots, 19 positive cells are all gated here. And the T and NK T cells were gated. If you have a further look at the population among all the B cells, do you want to call this clonal, non-clonal when you look at kappa and lambda? So you want to call it kappa restricted, right? So if you want to call it kappa restricted, let me point you to this population which appears to be expressing lambda in a very strong manner. So grossly, the only atypical finding that I see on this plot is that the kappa light chains, they are very, very diminished. So normally my normal cells sit somewhere over here. Now this has moved to the left. However, there is something which is sitting lambda positive as well. So no clear-cut indication of clonality. So it is important to look at other markers in the tube as well. So in this case, if we look at 19 and 5, we realize that one of the B cell populations expresses 5. The other one is negative for 5. Agreed? Yes. What about 20? One population bright for 20, the other population dim for 20, right? So let us get the 5 positive B cells and the 5 negative B cells separately. And let us go to the 20 versus 38 plot. So you realize that the CD5 positive B cells, they are dim for 20, right? While the cells that are 5 negative show a very bright 20 expression. Agreed? Yes. So now let us look at the kappa and lambda plot. What do you see? The 5 positive B cells, they are showing a very dim lambda expression. And my cells which are 20 bright, 5 negative, they are showing lambda, sorry, they are showing kappa expression at a bright intensity, right? So now what do you infer? You have two distinct clones here. You have 19 positive, 5 positive, 19 negative, 5 positive. This is the pattern. Look at the further tubes. In the further tubes, you see that you have the blue cells, 5 positive, which are also expressing 200 and which are also expressing CD43, 79B is them. So this is a CLL clone. While the bright 20 positive cells, they express 79B and they have heterogeneous 200 or dim 200 and they lack 43 expression. So basically, this was a non-CLL B cell clone. So in this case, what was the problem with kappa and lambda staining? There can be biclonal populations, right? So you had two B cell clones, one of which was kappa restricted, the other that was lambda restricted. So if you just were looking at total B cells in the system, you would not make out clonality very well. However, you can resolve it if you analyze the immunophenotype further. So this can exist as two separate B cell clones, like I showed you, with two different immunophenotypes. Sometimes even in the same disease, you can have two separate clones. So assessing the entire phenotype is important rather than relying isolated on the kappa or lambda staining. So a different approach is if you color the kappa positive B cells separately, lambda positive B cells separately, then also you may see this. So let us see how that approach will look like. So this was a 55-year-old male evaluated for lymphocytosis. And if you look at this, you have your B cells over here and you have kappa and lambda. Overall, I've given you percentages here. So lambda appears to be much more than kappa. Lambda is 82%, kappa is 17%. So definitely you have lambda clonal cells. Why? That 0.3:1 value will be fulfilled. However, let us see what happens when we color these two separately. Okay. So if we color the lambda positive cells pink and we color the kappa positive cells blue, what we get to see on the pink cells is that they express 19 and 5. And they also express a very dim 20, right? So CLL clone definitely. What about the blue cells? They express 5 slightly at a dimmer intensity, and they also express 20 at a dimmer intensity. So this is a case of CLL where there are two clones, one expressing kappa, the dominant one expressing lambda, and the minority expressing kappa. And if you look at further tubes, you realize that the entire B cell population is positive for 200. It expresses 43 at a dim intensity. It is 79B negative. So practically fits in with all the other findings of a CLL. So this is a biclonal CLL having two different clones but the same disease. So take home message for B cell clonality is, remember that the normal kappa lambda ratio as expected on a flow cytometry dot plot is 3 to 0.3. You do surface staining for B cell lymphomas, cytoplasmic staining for plasma cell disorder. But keep in mind the key points when we are going to do a kappa lambda staining: washes and blocking if required. Remember that if you are choosing a panel today, it is better to go with polyclonal reagents, especially for germinal center lymphomas. If you have 19 positive, 20 bright cells which lack the expression of light chains altogether, that also is an abnormality. CLL cells may have dim to absent kappa or lambda expression. And remember the biclonal population. So analyze the entire phenotype of the B cells in toto rather than just looking at the kappa to lambda ratio. With that, if you have any questions on B cell clonality, I'm happy to take them.
How far is the biclonal CLL important and does it change the strategy?
No, it does not change the management of the disease. right? These cases, thankfully, are not frequent. They are rare cases. I showed you two because these cases pose a diagnostic challenge sometimes, especially if the clones are nearly equal in size or if the kappa to lambda ratio of 2:1, for example, is maintained. So this was just to show you that kappa or lambda, even if they look like they're polyclonal, if you analyze them separately, you may sometimes see that an abnormal clone is sitting expressing those rather than a polyclonal pattern. So with that, we'll move gears, we'll shift gears and we'll move to T. Yeah. Yes? Hmm. Yeah. So in that case, do you need to assess the clonality? CLL has a very distinctive immunophenotype, right? Dr. Rashmi will show you those immunophenotypes when she talks to you about them. They are so distinctive that even if the kappa and lambda hasn't worked well, because even if it works, it is expressed at a dim intensity. So even if it hasn't worked, if you have the right population there, you know that you're dealing with CLL. Now for T cell lymphoma, again for clonality assessment, gene level, same three techniques. Protein level, you have B beta repertoire and the TRBC1 antibody now. So for T, you have multiple genes which need to be assessed. So if you look at the T cell receptor protein, there are 4 genes that are involved. For clonality, you use TCR-B, TCR-G, and TCR-D genes. So these are the set of primers, again, the EuroMRD consortium. And what they say is that if you have a suspected T cell proliferation, you go ahead with the TCR-B tubes and TCR-G tubes. But if you have a gamma delta proliferation, in that case, definitely the TCR-D tube should also be done. This is dependent on the rearrangement of the TCR gene. So the first entity that we know of for T cell clonality is B beta antibodies. And for T cells, for the longest time, when we talk about the proportion of T cell lymphomas, they are only 15% of the total CLPDs or total lymphomas. So that's an uncommon disease. Many of the T cell lymphomas actually occur in deep tissues sometimes. They occur in skin sometimes. So they are not usually flowed that well. So I don't think a lot of us pathologists have invested in buying the V beta repertoire kits for determining T cell clonality even in the normal scenario. So what we rely on for T cells commonly is the phenotypic differences from the normal T cells or deviations from the normal T cells. And I'll talk to you more about those in my subsequent lecture. But if we have to truly assess clonality, this is a set of 24 antibodies that are available targeted to different T cell receptors. So these are TCR variable beta region specificity, 24 different families, and they cover approximately 70% of the normal human B beta repertoire. So the percentage is slightly higher for the 4 positive cells versus the 8 positive cells. And this has to be compared with the normal ranges, which are given in the kit insert. And the maximum percentage of any of the V beta regions is 14.2% for helper T cells and 13.8% for cytotoxic T cells. The definition of clonality is if you have a single TCR V beta that is more than 10-fold its normal maximum, or as a percentage constitutes 50% of the T cells in any analyzed population, it is abnormal. Now remember that V beta, even if you do everything, you don't cover 100% of the T cells. So the second point comes in here that if your 70% cells or more, they fail to react with all these V beta, then also they are abnormal because 70% of those should have reacted. But if they don't react, that is itself is an abnormality. So this is from one of the first papers on V beta repertoire. And if you look at the conjugates in which these antibodies are available, you'll realize that most of them are available for FIT3 and PE, while as you move ahead in the conjugate line, the appearance of these antibodies becomes rarer. So most of the studies which are published on V beta have been done using this Beckman-Coulter kit, which is the IO-test beta mark repertoire kit, in which you have 8 tubes in which these antibodies are multiplexed in a manner that you have one of them conjugated with PE, the second conjugated with FIT-C, and the third antibody which is conjugated with FIT-C and PE, which means that both FIT-C and PE are bound to the same molecule and given to us. So in this case, what happens is, this is one of the kit inserts. So what it shows you is that this particular V beta 5.3, it is on the FL2 channel, that is CE. You have V beta 3 on FITC, and the third V beta 7.1 is conjugated with both FITC as well as CE, so it will come in the double positive area. So this is the kind of spread of a normal peripheral blood sample on which the company gives you a clonogram which you can make of each of the V beta percentage of the antibodies. And this is an example of the clonal tube. So if you have a look at the clonal tube, you realize that these cells, they are 8 negative. So they're talking about the helper cells. They've only added 8 and 3 along with the other antibodies here. So in this, what you see is that you have nothing here, nothing here. So a lot of V betas are not expressed, but the V beta that is expressed here is V beta 2. So a clear clonal population, very, very minimal expression of all the other V beta tubes. So Prashant has published papers on it. I think he worked on it when he was with Marianne Sylvester's group. So this was a modifying gating strategy that he used. And in this modified gating strategy, instead of analyzing all the helper cells or all the cytotoxic cells, he said if we restrict to the CD3 dim population, which is 4 positive, then the clonal population would come out to be better. So if you have a look at this one, if you analyze all the helper cells, you are at a threshold of 18.25%. You need 50% or more in an analyzed population. But if you restrict your analysis to this particular part, it sort of increases. So V beta repertoire, not many of us do because the costing is such that it does not work out. Plus, you need to put 8 tubes in addition to your T cell immunophenotyping, which means that you need that much amount of sample to go with all the tubes. Thankfully, life will be easy with TRBC1 and TRBC2. So TRBC, when you look at that, so if you look at the TCRB gene, there are 2 constant regions here. So one constant region is the TRBC1. The second constant region is the TRBC2. And they have very minimal differences in nucleotide, but these T cells, when they rearrange their TCRB gene, they select either TRBC1 or they select TRBC2. So this particular B cell has selected TRBC, this particular T cell has selected TRBC1 and this particular T cell has selected TRBC2, right? So the pattern that you have is a normal sample will have an admixture. So this is TRBC1 positive and by default, the blue cells, they are TRBC1 negative. So if you look at the x-axis here in the paper that describes TRBC1 for the first time in clear detail, this is 3 versus the anti-TRBC1 antibody, the clone is TROV1. So the TRBC1 antibodies, positive cells, positive T cells are red. The ones that are TRBC1 negative are blue, right? So it is splitting into these 2. Neoplastic cells, on the other hand, would express either TRBC1 or they will express TRBC2. Now, this is as per the ontogeny. So in the first paper itself, they described that TRBC1 could be used both as a surface as well as a cytoplasmic cell. So on the left is an example of a TLGL. So in a TLGL, you have the 8 positive cells here. And in the 8 positive cells, you realize that most of them are actually TRBC1. So it is not a 30-40 split or a 50-50 split. It is nearly everything is here. This is another example in which you see that most of your CD8 positive cells here, they are TRBC1 positive. And when you look at the LGS, nearly 100% are sitting as TRBC1 negative. So either everything TRBC1 positive or everything TRBC1 negative in your selected population of interest becomes abnormal. On the right is an example of an acute lymphoblastic leukemia. So on the acute lymphoblastic leukemia, when you look at all the blasts, you see that they either express TRBC1 or in another case, they lack TRBC1 expression, which means that you can use it right from ALL to lymphomas. Till now, most of the published papers are for lymphomas. So when you want to assess TRBC1 as a tool for T cell clonality, you cannot assess it in a marker combination which only has 3, 4, and 8. You need other markers to resolve it. So you have to assess it with an 8 to 10 color marker combination. Preferred would be to have multiple T cell markers, so CD3, 4, 8 to split your cells, to identify CD3 negative cells or to identify abnormal T cells with loss of 5, loss of 7, loss of 2. You would want CD2, CD5, and CD7. And you also require the presence of TCR gamma delta either gamma delta or alpha beta. If you have both, great, but at least one of these you should have. So with that, these are examples of two cases. So if you have a look at the case on the left, so this is on the CD3 positive, and you see that the red cells or the abnormal cells, they are positive for CD4. When you look at 26, they lack 26, but they are 7 positive. And when you look at the TRBC1, so most of these cells, they are negative for TRBC1. And you know that the antibody has worked well because the background cells, 4 as well as 8, they are splitting into two populations. Now, the example on the right is a case of Sézary syndrome. Again, 3 positive, 4 positive, lacking both 7 and 26. And these tumor cells are positive for the TRBC1 antibody, right? So this gives you a clear sign of clonality. In addition to that, again, this is another example of how the TRBC staining can come. So this was the case of a FGL. You had 8 positivity, 5 dim, 7 dim. And when you look at the TRBC1 expression, it is dim, but it is definitely positive. So the peak is not overlapping with the negative peaks of 4 and 8. So it is shifted to the right. It is not just bright positive. Okay. So this particular pattern also exists with TRBC1 antibodies. So if you look at the lymphomas that these investigators, and this was Horner's group, what they studied was that lymphomas either express TRBC1 or they do not express TRBC1 tumor cells. They don't have intermediate expressions, which you have for the normal CD4 or 8 positive events. Nothing comes without its limitations. For TRBC1 also there are limitations. It will not detect clonal gamma delta T cells. Why? Yes, so it needs to have the TCR-B gene present on the surface, the product of TRBC, like the product of the TRBC T cell receptor beta rearrangement to be present on the surface. Now, again, the second component is जितना आप marker बाकी डालोगे, उतना आपको better information मिलेगा. So if your T cell clone is a small clone and it hides within the normal T cells, you will not be able to pull it out using TRBC1 antibody because the normal cells will overpower it, right? For example, if you have a case in which you have a T cell clone, which is 8 positive, shows a slight loss of CD5, and this clone is only 2%. You may miss it if you don't have adequate markers to pull it out well. Now, the third component is that because you have added TRBC1 antibody, and if you have a good panel, you're able to identify small populations which are definitely clonal, but they don't have a definite significance. So Horner's group suggests that this T cell cytopenia, like T cell clone of undetermined significance for 8 positive, 4 negative cells, which is the most common of such clones, they say that if they constitute 15% or more of the lymphocytes, then only they should be considered clinically relevant, or otherwise you keep a note that they need to be followed up. And now Horner's group, what they've tried to do is that when you talked about kappa and lambda, B cells express either kappa or lambda. The same way T cells, whenever they will undergo a TCR beta rearrangement, they would express either TRBC1 or they would express TRBC2. Earlier, we were seeing that TRBC1 negativity, whatever is negative is positive for TRBC2. That was an assumption that we had. So what they did was they took the TRBC1 antibody and they modified it. They modified it, changed the nucleotides that were different to form the TRBC2 antibody. And this is a mutated TRBC1 antibody essentially. So based on that, if you look at these dot plots, now you're able to see clear splits. So on the alpha beta positive cells, you can see the TRBC1 positive and the TRBC2 positive cells, same thing on the 4 positive cells, same thing on the 8 positive cells. So effectively, whenever this antibody is now marketed, and in fact, Beckman has started marketing this antibody, so we can actually use it and use it like kappa and lambda staining for B cells. So this is an example again in Horner's paper, and you see this particular case. You have the lymphocytes here. This is from a Sézary syndrome. You have 7 partial loss, and you have 26 complete negative cells, which are your Sézary cells. These Sézary cells, they express TRBC2. Earlier, these cells would have been called as TRBC2 surrogately because they did not express TRBC1. Now, the same thing again for cytoplasmic assessment in a TALL. Again, you have cells which are 99 positive, which are 4 and 8 dual positive, and which are showing you TRBC2 expression. So this is where I'll finish about the T cell clonality. The take-home message is that when we talk about clonality assessment in T cells, we only have two tools: the V beta repertoire, which is costly, which uses these thresholds to identify positivity. However, the advent of or the incoming of the TRBC1 and possibly the TRBC2 antibody in future will help us assess clonal T cells better, and these antibodies are better analyzed with a large panel of markers so that you can tease out your population of interest better. Remember that TCR gamma delta positive cells, you should not look at TRBC1 antibody. And when you don't have surface 3 expression, at that time, you cannot call a population as abnormal based on the lack of TRBC1 alone. Why? Because the T cell receptor, when it is expressed on the surface, at that time, CD3 has to be positive. So if CD3 is not positive on the surface, then you have to use a cytoplasmic step to ensure that the antibody, you're able to detect what you want to detect. And the resolution of small abnormal populations will always be dependent on the other antigens. And remember the concept of T, clone of uncertain significance. With that, I would like to thank, and again, my acknowledgements are my two colleagues. This is Ganesh, this is Richa. They are the ones working while I'm here. And Pratyusha, with whom who helped me out with the talk, with this particular talk. Thank you. I'm happy to take questions.